mechanism of attending to patients that we're calling integrated care or patient-centered care or patient-centered service delivery. And I have the privilege of taking us through the clinical pathways to integrated care and diagnostics in this day.
Looks like Dr. Roni has a challenge. Can the IT share screen for you, Dr. Roni?
No, it's just that there was a process going on in my.
Okay.
Okay.
Go ahead.
So as our background, colleagues, we need to appreciate the fact that this discussion that we're having today and the discussions that we shall have in the several weeks or months coming are all premised on making sure that we align ourselves to the government priorities that are seeking to emphasize equitable access to high quality, patient-centered health services for all of us as Ugandans. And this is seeking to optimize the available resources that we have as a country. And this is consistent with the National Development Plan 4 that is speaking about program-based planning, where you find integrated or interlinked services all being provided under similar programs, just to make sure that we do not duplicate ourselves, but rather we synergize efforts to make sure that we are able to deliver collectively for the benefit of the population that we seek to serve. But then also, as we do that, we ought to use the limited resources as minimally as possible, but maximize the outputs out of those resources. And drawing from what we have been implementing in the past, we've in the recent past had programs that have been established to focus on particular diseases, and this was intentioned to make sure that we emphasized the specific needs or requirements that were arising from the special attributes that these conditions come with. A case in point is HIV/AIDS, TB, or non-communicable diseases, where we have found ourselves establishing standalone clinics or standalone healthcare services that are aiming at addressing the specific concerns of those categories of people. But we should realize that as we were doing this, this called for intensity in resourcing these services to make sure that we were able to effectively deliver this. And as we were doing this, we noticed that we were not fully attending to the needs of those that came to us as patients, because we tended to focus more on the disease rather than the patient that was always before us. And it's a reason why today we are discussing this shift, where we are moving away from verticalized or disease-centered or disease-focused approaches to patient care to an integrated modality or approach where we're going to be seeing a patient as a patient rather than as a disease. And this calls for making sure that when a patient comes to us, we are able to see this person holistically, interact with them, explore all the conditions that they could be having, and be able to address all these conditions at one sitting, what we are calling integrated service delivery. This has been a long time in making, and we should appreciate the fact that it's not the first time that we are discussing integration. As a country, we have been in the process of discussions to ensure that we are able to come together and speak to each other and see how best we can harmonize and harness the resources that we have. And therefore, I need to extinguish the notions that whatever we are discussing is informed by the executive orders as happened in the United States of America and are being attributed to the withdrawal of donor support in the country. No, As a country, we've had this conversation for quite a long time, and we all realize that the circular that was generated by the accounting officer of the Ministry of Health was issued or was authored shortly before the executive orders were effected or were announced. And that means that as a country, we had our own plans ahead of time. And this was aiming at making sure that we optimized the services and we were having a system, a healthcare system that was responsive to the needs of the population rather than the disease-based approach that we were implementing as a country. And you realize that when this circular was issued, there has been a practical guide that has been developed by so many minds through an integrated consultative and intense consultative process to make sure that we are able to put our minds together and see how best we will be able to move away from the disease-based approach of patient care to the patient-centered care approach. And this will be speaking directly to existing documents that we already have with us, which speak to patient care, especially the Uganda Clinical Guidelines. That is, as you can clearly see here in its label, it is national guidelines for management of common health conditions, meaning that it's a document that brings together all aspects of patient care. And it's not a document that is speaking about just one condition, but rather every condition as exists in the country, as was developed with all the minds and consultations from all the different constituencies to make sure that we were as inclusive as possible. And as this process was being done, or as we are doing this process, we are seeking to answer to the expectations of the National Essential Healthcare Package, which is seeking to standardize care and bring services as close as possible to each and every person in this country. And this is seeking to as well promote access to these services in a much more equitable manner. So we will realize that this circular was developed on the 7th of February, and we are seeking to phase out the verticalized or standalone clinics or healthcare services that we have been offering in our facilities. And this will be delivered through the practical guide that has been developed to make sure that we are able to follow a systematic way as we implement this agenda on integration. We appreciate the fact that some facilities have already started on the journey of integration, and we will have vast lessons that we will learn from, that we will draw from them in making sure that we are able to carry each other on this journey. We appreciate the fact that all of us will start the journey almost at the same time, but we will not run this race at the same pace. There are those that will delay, there are those that will be fast, and there are those that will be moderate. So we just need to be able to benchmark and keep drawing lessons from each other because of the different contexts that the country is or lies in, and that will require intense support from all over. It will require support from the leadership, it will require support from the healthcare workers themselves, or we ourselves, and it will require support from each and every square to make sure that this agenda is a success, because it's the best way that we can optimize the resources that we have as a country as we seek to serve those that we take oath to provide services for going forward. So what has been prepared for us in this practical guide? You realize that this practical guide has got particular sections that is focusing itself to that we will expect at minimum of all of us to be able to understand. One, we need to understand that we have a purpose for which we are setting out this agenda. So this guide has layouts of what exactly it's intending to achieve in terms of the purpose, the scope, what exactly it's going to cover over the period of time that it has been set out for. And then we'll have the audience that we are seeking to address these interventions to, as well as the objectives of this particular intervention that we're seeking to implement at this point in time. And looking at the standards that have been spelled out in this practical guide, standard 1 is seeking to address the concerns or the roles of leaders and managers in the integration agenda, where we are calling upon each and every leader, wherever you are, as a manager, as a political leader, as a social cultural leader, to make sure that we are able to develop plans with our healthcare system and make sure that we are able to pursue this integration agenda. Only then are we going to have the buy-in of the healthcare workers that we're seeking to bring on board and make sure that the patients that we seek to serve are indeed benefiting from the services that we are offering in the different facilities that have been set out. And this is going to go beyond just the healthcare facilities to even the level of the community. As we all are aware that the healthcare system in this country does not only speak to hospitals, but rather it extends to the community. And this is a reason why we have a community engagement component in our healthcare service delivery landscape. 2, we are seeking to have all the health facility managers establish clinic spaces to ensure that we are able to deliver integrated services. And in this, we are looking at providing spaces that will address the concerns that are acute in nature of the patients that they present with. And this should not be confused with the chronic requirements of patients, meaning that when we move or transition to integration, colleagues, we need to realize one fact that the integration agenda that we are calling for right now, or the patient-centered care approach, is one of the things that we started off with long before we started verticalization of care. And this is the time that we are calling us to go back to that basic level of care. And as we call out for this, we need to realize that we are not saying that specialization and super specialization of services will no longer suffice, but rather what we're calling out for is at primary health care level, there should be integration by all means. And we should not be seeing super specialization at primary healthcare level. This provides for specialization and super specialization at the secondary and tertiary levels of care, but not at primary healthcare level. And that's the reason why we're looking at providing for acute and chronic care at the different levels, as we'll be able to display this or share this in the different care models that are going to be shared at a later point in time as we go through. And then as leaders, facility leaders, we will be expected to conduct comprehensive patient-centered clinical assessments, as well as care for the patients that we have before us, as well as implementing service delivery approaches that are seeking to foster efficiencies, as well as quality of care, amongst all the things that we do during our day-to-day. Standard 3 is looking at logistics or supply chain management. And with this, we look at the pharmacies where the in-charges must ensure that we have uninterrupted supply of essential medicines and diagnostics to make sure that we are able to always be responsive to the needs of the patients that we care for. And as we discuss all these things, colleagues, it suffices to say that we will have healthcare systems that are going to enable us deliver this model of care that we're calling out for. And that's what we look at in Standard 4, which is looking at the standardization of the National Integrated Health Management Information System. We all are aware that the accounting officer of this ministry has been the chief advocate of electronic medical records usage in the facilities to make sure that the healthcare system is responsive to the needs of the patients that we care for by helping us as healthcare providers to consume the data that we use in planning and in making sure that we have services that are responsive to the needs of those that seek them. This is one of the approaches that we're going to use as much as possible to make sure that we are able to deliver this agenda. And we take this opportunity to call upon all the facilities that have infrastructure installed for electronic medical records to go ahead and functionalize this without fail. And for those that haven't gotten this infrastructure yet, you can be benchmarking in the meantime and making arrangements on receiving this infrastructure and how you're going to implement it going forward. Standard 5 is speaking to optimization of the human resources that we have, as has already been alluded to, colleagues. We are looking at a scenario where one healthcare provider, say a doctor at OPD, will not only focus on one disease, HIV/AIDS or hypertension or diabetes mellitus or whatever it is, to seeing a patient that comes in with whatever conditions that they have. And this can only be obtained or can be at best achieved if we are able to go back to the basics of patient care, where we are able to take effective history from the patients, examine them appropriately, and use all the available diagnostics that we have with us to make sure that we are able to make that appropriate diagnosis for appropriate prescription. And this, we believe, if we are able to implement effectively, will be able to help us address one other emerging epidemic in antimicrobial resistance as well. And with this, we believe we are going to promote effective utilization of the diagnostic systems that we have with us. In the recent past, because of verticalization, still have had lots of disconnect between the clinical care teams and the laboratory teams or the diagnostics teams, where you find that clinicians generate requests for diagnostics, be it laboratory or radiology, send them to the diagnostics section. Tests are done, results are generated, but these results are never streamed back to the clinicians. The clinicians go ahead and generate prescriptions, and patients go away on empirical treatment. And what that has done to us has been largely to grow the bug of or the vice of antimicrobial resistance, which we believe with this integration, things will get a little better and we'll start speaking to each other a little much better, and we'll start realizing the value in doing whatever we're doing for the benefit that it brings into patient care and optimization of the resources that we have. And as already spoken to, Standard 7 is going to be looking at how we're going to integrate our services at community level to make sure that we are able to prevent diseases and through health promotion at community level, and make sure that only those that are fit to come to the hospitals, meaning that they have breakthrough infections or diseases, are the ones that access hospitals. And that will only serve to help us in making sure that we reduce the burden of or the load of patients that come to hospitals, because of much of the preventable conditions shall have been attended to. And those few that will come will get optimum care, because the numbers will be very few, and it will help improve the patient healthcare worker ratios, where the patients will be the final and endpoint beneficiaries of that arrangement. So what do we seek to achieve through this integration, and what is the focus of this practical guide? One, it's seeking to make sure that we are able, as healthcare workers and managers, to integrate disease programs or services within facilities. And this is focusing on primary healthcare service delivery, where we seek to promote efficiencies and patient outcomes. And we hope that this will apply to all the healthcare service delivery landscape in this country.
I seem not to see the slide properly. I don't know whether it is clear for others.
You don't see it? I think it's the font. Can you see it better now?
Okay.
Can you see it better?
Okay.
Can I proceed, Chair?
Colleagues, are you able to see?
I could change the format.
I think the slide is a little blurred.
It's okay.
So we can ask Isaac to help us project it. Isaac, can you help project it?
It's still the same slide, but I can just speak
Okay.
through it, Chair, because it's still the same things that we've already discussed. And I was just trying to emphasize to us here that the scope of this practical guide is public and private healthcare providers, both private not-for-profit as well as private for-profit, for as long as we all subscribe to the healthcare service delivery model in this country. And this is seeking to address all of us as healthcare workers, healthcare service managers, as well as the implementing partners. So the role of the implementing partners in this case is to make sure that we no longer support services in a vertical manner, but rather in an integrated manner. If you have resources that are geared toward TB, HIV/AIDS, let TB, HIV/AIDS be an entry point into supporting the whole entire healthcare service delivery landscape. Get to the facilities, ask for the priorities of the health manager, let the health manager guide you and direct you on how best you can utilize those resources, rather than you coming as an implementing partner and saying, for me, my resources are here to support only HIV/AIDS. They are here to support only TB. TB will be an entry point. And when you get there, seek out for the priorities of these healthcare facilities and be seen to implement comprehensive healthcare service delivery at that level. And with this, we hope that we'll be able to implement the Ministry of Health as Isaac. I kindly request that I retain my slides.
It's okay. You can share from your side.
Okay. So the objectives of this practical guide that we are discussing now, establishing a patient-centered one-stop care model for healthcare service delivery in the country. And this seeks to improve access to quality diagnosis, treatment, and care for the patients that we have. And as we do this, we believe we'll be able to optimize the resources that we have available to us, both financial space as well as the workforce. And we believe at the end of the day, once we are able to implement this integration agenda, then we will be able to redefine and re-anchor ourselves along the national referral system, which has to date failed because of the way we implement services in this country, where each and every facility, each and every healthcare provider is able to refer patients far and beyond the levels of catchment of the facilities that they serve at. And you find that with the different resources that are brought into the different healthcare model, spaces, observation or adherence to the national referral cascade becomes complicated. But with this, we believe we'll be able to strengthen the referral system, especially for specialized care, meaning that as the primary healthcare providers will be seen to address the patient concerns, and only those that are warranting of specialized care will be escalated to higher levels of care at the regional referral hospitals and the general hospitals, regional referral hospitals, as well as the national referral hospitals that will be having the specialization of services as has been provided for already in our human resource structures that were recently released. And with this, we believe that we will be able to enhance data utilization as well as reporting and surveillance of the diseases that we have within our facilities, and especially utilization of the data on mortality, which has been until to date a big miss in the low-hanging fruits that we could best utilize to improve healthcare service delivery in this country. We have a lot of data that we generate, but because we don't consume it, at the end of the day, we lose the opportunity of informing our interventions toward particular conditions that are ravaging our communities.
Yes, Ronnie?
I think I got a disturbance in my connectivity. Can you see my slides, Chair?
And that's why I wanted the people in the secretariat to share. Sometimes we can see now they're back.
Okay. So, colleagues, what is going to be expected of us in standards 1 and 2, as has already been highlighted earlier, is as leaders, we are expected to first and foremost buy into this new agenda of integration of services, and this calls on each one of us as leaders in whichever category of leadership we are. You can be an in charge of a unit, you can be an in charge of a lower level healthcare facility, you can be an in charge of a general hospital, up to the level of the executive directors of the national referral hospitals. What is expected of us is to make sure that we embrace this ideology of integration of services. Services that can run together should be provided together rather than split up for the sake of specialization. Rather, what we should be seen to do is promote the aspect of optimization of those minimal resources that we have as we seek out to support the patients that come to us. And the most culpable services where we've had a lot of verticalization has been in outpatient services, where we've had lots of services running as standalones. HIV, which is an outpatient service, HIV care has by far been running separate from the general OPD. And at this point in time, we're calling for integration, where the action plan that is going to be developed should speak to an integrated primary health care model that seeks to provide services under one roof. There will no longer be a patient for HIV/AIDS. There will no longer be a patient for hypertension, but rather all patients will be coming to the facility and getting services at one sitting. The key questions or the key worries that many of us have expressed as we were building up this narrative was, isn't there going to be stigmatization? Isn't there going to be an increase in patient load at the outpatient where the HIV/AIDS patients, or no, the people living with HIV/AIDS will now find it difficult accessing their medications, where they will be delaying in the facilities, which could compromise adherence and compliance to their treatment. Colleagues, as we are doing this, there is a back end of the systems that are being developed to make sure that they support and anchor this narrative. We've talked about the electronic medical record system, which is seeking to improve retrieval and access of an entire patient record or person's record from whenever they access the facilities and from wherever they access the facilities. In a way, this is going to help us in addressing this concern of delays that we see, or that is being feared for at the different facilities. And we believe if as managers of some of these systems improvements that have been introduced, then we should be able to address some of these concerns, and we should serve our patients or those that seek for these services from us much better. And we will definitely continue monitoring the feedback from those that are seeking and receiving these services through the client feedback mechanism that has already been introduced and is operational. We all are aware about the QR codes that were introduced in the facilities to provide electronic feedback to the Ministry of Health over the client satisfaction of the services that we offer and to the patients. So these are mechanisms that we will continually review to make sure that we are able to draw lessons from the direct feedback of the consumers of our services, and make sure that we are able to improve on the go as we institutionalize this agenda of integration. In establishment of clinic space and the management of conditions, either acute or chronic, the role of the health manager is going to be in making sure that we repurpose the clinic spaces at the OPD and use the available tools that we have with us to make sure that we are able to screen out for all the different conditions at each and every visit rather than seeking out for just one particular condition. And this is going to be the primary role of the nurses that man the triage areas, as well as the clinicians that are seeing these patients, to make sure that at each and every time when you are interfacing with the patient, you are able to see this patient holistically and pick out whatever conditions that they could be presenting with and manage them as such. So this is a schematic flow of or demonstration of what exactly has been happening and what we are advocating for. When you look at this picture on my left, when you look at this picture on my left, it's speaking to what exactly we see in the facilities that we have a general OPD for general common conditions. We have an ART clinic, which is also an outpatient clinic. And then we have, in some hospitals, diabetic clinics. We have hypertensive clinics. We have all kinds of clinics, especially at primary healthcare level. And this calls for having healthcare workers, the whole entire cascade of healthcare workers or setup of healthcare workers at the general OPD, because you're addressing the concerns of the patients therein. You have another set of healthcare workers providing services at this level. You have another set of healthcare workers that are providing services at this level. And then you also have another set of healthcare workers that are providing services at this level. And moreover, at primary healthcare level. Which to remind us of this integration agenda in optimization of resources, we felt that it wasn't worthy for us to continue splitting ourselves wide and thin and not delivering the services of those that come to us as effectively as desired. So this is the new picture that we expect to see at the different facilities, especially at primary healthcare level. Let us have our services under one roof. A person presenting with HIV/AIDS, or a person living with HIV/AIDS, and a person that has a common condition like malaria or a common cold can all be seen under this area here. And the clinician should be able to have the capacity to discern or detect whatever conditions the patient is presenting with, and therefore be able to manage them appropriately. For the fear of stigma that many of us have been fearing about, we feel that this was a worse stigmatizing environment, because whoever accessed this facility, because they were always in the open, was branded a person living possibly with HIV/AIDS. And we believe with this integrated under one roof service care model, there will no longer be any aspect of branding of people that, oh, that person has HIV/AIDS or that person has this condition, because there will no longer be any identifiers since we shall have taken away that whole entire aspect of vertical setups of these services. So for primary healthcare levels, what we are expecting to see, we want to have one care model and one care point where all these services are delivered at the same sitting. And for those at higher levels, like general hospitals where specialization is beginning up to the quaternary level, then there we can have an aspect of specialization or separation of services. Why? Because at that level, the needs of the patient start getting a little escalated, and the requirements may need an in-depth engagement or involvement of the different super specializations. And that's the reason why we are starting to see an aspect of separation, where you have special needs being taken care of by the different categories of healthcare providers. So in the standard of assessment that, or clinical assessment, that is standard 2, that is looking at a clinical care assessment of the patients that we're looking at, as has been highlighted in that schematic flow, what we expect to see is when a patient walks into a facility, as opposed to the past where we have not been emphasizing these clinic care flows of patients and healthcare workers. Now we are coming out to define the patient flow within a healthcare system. And this is in cognizance of the fact that we are not only dealing with common conditions, but we also have some of those conditions that are capable of causing public health emergencies or outbreaks. And it's important, paramount for us as healthcare providers to ensure that we go back to the basics of ensuring that we are able to protect ourselves first. And the only way we can be able to achieve that is by establishing screening points within our healthcare facilities. So when a patient accesses us, we need to be seen to screen them right at the get-go when they are accessing the facility. And this is primarily for us to be able to know what exactly we are dealing with. If it's a patient that is presenting with a public health, a condition that has a potential for a public health emergency situation or an outbreak of sort, then we need to be seen to separate that person and define a different flow for them. If it's a person that is presenting with then a common condition, malaria or a common cold, or people have their own chronic conditions, then we should be seen to also direct them otherwise within the healthcare setting. And this will then be seen to point these patients to the different triage points that are going to be used to classify these patients as either emergency or routine care. And based on that, then they will be sent to the reception areas where they'll be registered of their demographics. And we're encouraging use of the electronic medical records for all those facilities that have this infrastructure in place to make sure that we are able
Commissioner,
to.
we need to move a little bit fast.
Okay, I'm so sorry about that. I thought I had all the time. I'm so sorry about that, Chair. Then we need to be sent to conduct integrated health talks on disease prevention, lifestyle modification, and adherence. We need to check whether these people are on appointment or not, especially for those that are coming for chronic care. We're talking about people that are coming for HIV/AIDS follow-up care. We need to take basic demographic data and enter it as accurately as possible, because if we do not enter it accurately, retrieval becomes very complicated, and that means that data becomes useless. And then we need to allot identifiers to the new people that are accessing care for the first time. And then we move to the next level, which is patient-centered individualized treatment care plans that are only constructed based on appropriate diagnoses that have been made. And with this, we are calling upon all of us as healthcare providers to go back to the basics of patient care. Take a very good history, examine the patients, and make sure that you fully investigated these patients, and you make a very good and appropriate diagnosis so that you can be able to make appropriate prescriptions. And it's through appropriate prescription practices that we will be able to get rid of the aspect of antimicrobial resistance. And then thereafter, once you have been able to make your prescription, then you can be able to design a follow-up plan for this patient, whether they'll need to be, whether they'll need to return or they're not required to return. If they require referral, you still go ahead and refer them as appropriate as possible. And as we do all this, we need to realize that there are going to be systems that are going to enable these mechanisms that we're talking about to make sure that our processes are as seamless as possible. Yeah, thank you so much, Chair, and I'm sorry about that. So in looking at logistics and medicines management, we are going to be, as healthcare providers, expected to manage medicines from an integrated model approach. where we'll be doing the quantifications and ordering of these medicines in a similar manner, as opposed to where we've been having medicines ordered for separately that was premising on diseases rather than on a healthcare facility requirements. And this is going to be seen to promote effective utilization and management of logistics and accountabilities at the different facilities. So what we expect is the pharmacists or the pharmacy technicians or logisticians at the different facilities should be able to go back to the basics of making sure that we are able to complete our stock cards appropriately and make sure that these stock cards match with the electronic logistics quality management information system, which manages our logistics in the pharmacy, in the different stores and pharmacies. This will still be the same way of care, where medicines will be dispensed at the same platform, as opposed to where we've been having different windows dispensing different medicines because patients were aligned differently. Now patients are all going to be aligned in the same areas, and we expect that people should be able to get their medicines in the same areas with the optimization of the different spaces that we have at the different facilities. HMIS and human resources for health, as has already been highlighted, we expect that we need to optimize these resources. But then key to note here is we need to make sure that we utilize the electronic medical records where it is. And for all of us as healthcare providers, for all of us as managers, we have DHOs here, we have hospital directors or senior executive consultants for the hospitals. We expect that we should be able to utilize our wage as much as possible so that we can be able to fill the different human resources for health gaps that we have in our facilities. And this is just a schematic flow of what we are going to expect when we are managing a patient who requires diagnostic investigations. For laboratory as well as radiology, where a patient will be seen and their records will be entered at the EMR point. And in that regard, the patients will be able to generate a request that will be sent directly either to the laboratory or to the radiology unit. And we hope that by going paperless, we'll be able to streamline and improve patient care systems within our spaces. Looking at the community systems, what we're looking at here is the health assistants, as well as the assistant district health officers in charge of environmental health should be able to advocate for aspects of disease prevention and health promotion to make sure that we are able to best utilize these resources in leveraging the community to make sure that we reduce the disease burden of those that we see in the hospitals. Recently, we have adopted the community health extension worker model of community health, and we believe with this we'll be able to promote health at community level and reduce the burden of patients that are coming to the hospital, so that we can be able to optimize the care that we offer unto those that come to us in the hospitals as breakthrough conditions. So what is it that we expect to see in our next steps? One is we will continue with this series of webinars to speak to more healthcare workers so that all of us can be able to embrace this integration agenda where we are now seeing patients in a common area rather than in a vertical disease-specific area. And we will be able to support the different facilities as we indicated with the different support systems. So we'll have the leaders at local level, we'll have leaders from the districts, we'll have leaders from the center coming in to support the different facilities in embracing this integration agenda. And as we already indicated, it may not be that all of us are going to run at the same speed, but rather we all have got to get to the end point where we are running integrated services. So whoever runs faster than the other, we will benchmark from that one, understand what context, how they were able to manage their context to establish their systems, and we will draw from those lessons to ensure that we are able to entrench and institutionalize integration going forward. And with this, we'll also continue using training and mentorship as modalities of enhancing the capacities of our health workers as we seek to deliver on this integrated care model. Thank you so very much, Chair, and back to you.
Thank you so much, Dr. Ronnie. It would not have been any other person speaking to the clinic care forum than yourself, our Commissioner for Clinical Services. We are very happy for the guidance and the different models that you have highlighted. Colleagues, you will keep your comments coming. We are going to go through them, and I request the Commissioner to also check in the chat, and colleagues who have been involved in the practical guide development. We can answer some of the comments directly, but we'll have some of those that have frequently not understood and discussed in plenary. I'll now request, we're not going into question and answer now. Dr. Kata Chiimba, you can note your question down either in the chat or now go into what is happening out there. We have people who have run this integration faster than the Ministry of Health. And this morning we have two colleagues. Experiences are going to come from the district. We have Dr. Kamya Ivan from Chirhura, who will be sharing with us how he has embraced the integration agenda. And then after Dr. Kamya, we'll have experience from Rira Regional Referral Hospital. Without wasting more time, I want to introduce Dr. Kamya Ivan and give you the mic to take us through your experience as a district. Over to you, Dr. Kamya. Dr. Kamya, please unmute him if you have controlled the muting so it is able to speak. Yes. Go ahead, Doctor.
Oh, yes. Are you getting me now?
Very well.
Getting me, Stabby? Okay, thank you very much. And Director General Stabby and everybody. Once again, I'm Dr. Kamya David Ivan, EHO Chirhura. I'm going to share the experiences of integration for Chirhura district. But before I start the presentation, Stabby, I want to make the following comments. In 2016, we had presidential directives over integration. And I think those documents are available at the Ministry of Health. We need to study carefully because the directives were clear about the integration of the services. And I participated in making those directives. And they are documented. But probably what went wrong, we need to start from the center and understand why did we fail to have integration when actually it was clearly written down in presidential directives for the sector. I believe that if we are to integrate, we need to begin by reorienting the center, the Ministry of Health, and the partners. Otherwise, I think the problem is not at district level. Next slide. Next. A background about Chirhura district. Chirhura district is located in the cattle corridor of southwestern Uganda. It's bordering Kazo, Mbarara, Lyantonde, Isingiro, Mubende, and Sembabule district. Chirhura district has 11 sub-counties and 3 town councils. And every sub-county apart from Makayanja has an ART site. We have 3 sub-counties of Chikasi, Rushere, and Chikasi, Rushere Town Council, and Kinoni, which have more than 1 ART site. Those ones have 2 because we have a private and a government in each of those, giving a total of 16 ART sites in the districts. As of 2024, the population census, the population of Chirhura was 21,11700, making it, but it's sparsely populated part of the country. Those of you who have visited this place, you know our population is sparsely populated. Now, for the last 10 years, Chirula District Sector we have been implementing a district-led programming model of quality improvement using locally generated solutions with support from partners. This approach has had a positive impact on all our sector outcomes. All our strategic activities, 1, planning, 2, coordination, 3, monitoring and evaluation of the service are integrated to achieve synergy and value for money. Chirula District Sector has been ranked among the top 3 in the other sector performance report for the last 3 years. 3 years ago, we are number 3. The year that followed, we are number 1. And last year, we are number 2, second to leader city. Next. Partners. Partners and LSA facilities are guided. How do we guide partners? This one comes from the time of even signing memorandum of understanding. When the MOU is coming from a partner, we normally have to sit down with them. They are partners, I don't know whether they're on the website, they are listening, like the partners of TASO. When we are entering the district, we sat with them for 12 hours to discuss the do's and the don'ts. And one of them is to see that when they are bringing in money for one activity, HIV, perhaps we can use that money to even go beyond HIV services and be able to deliver services for the population. Now, if you are bringing in money, I don't know whether Dr. Pigo is on the line, if you are bringing in money for sensitization of people about malaria in the community, when I go to that parish to sensitize about malaria, I go beyond malaria and I'm able to sensitize my population about sanitation, I'm able to sensitize my population about HIV, such that by the time I have left that parish, that community has got a complete package of services. This has actually for us resulted into improvement of the community level indicators for vaccination, HIV, and maternal child care services. I was initially sharing with the program manager UNEPI that in absence of money for Gavi, I've been able to use the money from TASO. When I go to test for HIV in the community, I'm able to vaccinate those children. When I go to follow up babies for EID integration in that parish, on that village, I immunize those children and be able to get it. When I go for, so that kind of integration service for us has played a big role for us for our improvement in services. Now, specifically now for integration of the HIV clinic, Chiruhura, I think Rationale Hospital started integrating one and a half years ago. They had problems in terms of finances and human resources. So they found that integration was more effective, and I think it was still another one of the models. But again, even Chirula Center 4 had come on board following the circular. And I've given you a guidance, which you can be able to see on the screen. Next, can you go to the next slide? Yeah, it is showing you how a patient is arriving in OPD at Chirula Center 4. There is a triage there. From the triage, the patient can go to the counselor, and from the counselor, the patient can either go to the laboratory, or you can, then from the laboratory, the patient can go to the clinician or to the pharmacy. I think we can look at how the patient flow is happening there. But we have started integrating at Chirula Center 4, and patients are coming in the end of the week, and we are managing them as the general integrated patient of care with other patients for the last, I think, 1 month from the time we got the circular. Next. Next slide. Patients are booked to come any day of the week to reduce the workload on what we used to call the AT days. LSA workers who used to provide, who were previously not part of the AT clinic, were oriented and trained through CME that the facility at Chirula Center 4 and mentorship by others. Seasoned AT clinic staff were retained in OPD to continuously guide others. Two peer mothers who were at Chirula Center 4, 2 peers actually who were in the OPD, we are retained, you know, the partners have actually left, but we retained them using PHC funding. At Chirula Center 4, anti-drugs are dispensed from the clinical rooms due to the open nature of the general pharmacy. At Rationale Hospital, the drugs are packed in envelopes and dispensed in the general pharmacy. Now, recruitment, I know the commissioner has talked about, perhaps we lost, following the withdrawal of funding for PEPFAR and partners, we have lost an average, we have lost actually more than 50 staffs. And this has created a bit of a gap. Recruitment is ongoing, and we hope that it may be completed either next month, I think by end of April, because we are already planned to recruit, but we have actually adjusted our recruitment plan to try to cater for a big section of the staffs we have lost following the withdrawal of this funding. Next. Sample transportation. Next is about sample transportation. We have written a circular. Yes, I think you're moving the slides faster. The slides should be able to move faster. You're on integration. We have written a circular to all facilities to guide them on sample transportation, and we are waiting for guidance from the circular from the Ministry of Health. Facilities use existing means to deliver samples to the hub, and we have also advised the DHT members who are actually currently down on support supervision. Whenever they go down, they have to pick samples and they bring them to the hub. We have emphasis on testing. We have communicated via WhatsApp platforms. We have 3 WhatsApp platforms. We have a WhatsApp platform for LSA workers, we have one for DHT members, and we have one for all other staffs. So we are communicating using these platforms to make sure that in case there is a coordination problem in sample collection, we are able to make sure that that sample reaches the district. But I must admit there are still some challenges. What are the challenges? Next slide. Go to the next slide. Next slide. Yes. Challenges. There is no written guidance from the Ministry of Health to guide the cows on absorption of critical staffs. I remember in the first Zoom meeting, Stavia, we said that the PS is going to write to guide the accounting officers and probably the subs commissions to prioritize the staffs who have been on for funding, and we have not got that letter. I'm worried some of these staffs may end up missing out, the ones who have worked for us for quite some time. So we need that letter down with us. Some staffs like sample riders, data clerks are not in the government structure. Of course, the staff shortages are already there. The other challenge which we have on M&E is that partners we are supporting people called data clerks. These data clerks were a bit better trained with a lot of IT skills, and we had people managing these EMR electronic medical records, and all of them have now left the facility. So we have prioritized actually recruitment of such cadres in the recruitment plan. But before we recruit, we believe that the need for capacity building of our medical records people who are there. Available means is not enough to transport samples in time. That is another problem. Next. What are we recommending? We are recommending the Ministry of Health to guide districts urgently, especially accounting officers.
Please change the slide. Isaac, next slide. Yes, thank you.
We are recommending the Ministry of Health to send guidance down about absorption of paper supported staff, like that the cows and the staffs commission can give them priority. Otherwise, we are worried that we may lose staffs who have gained experience over time in the upcoming recruitment of ours. And we also want to see like their posts like hub riders. I don't know how they are going to be filled. That's a bit of a challenge because they may not be in a public service structure yet. And we also need training of HIA in how to use EMR. And we're also waiting a circular from Dr. Navada there, Commissioner Laboratory, about how we are going to manage the hub. For us, we have written our own circular using our own, the way we know it, how we can be able to handle. But we are waiting for further guidance because the circular from the PS was very clear that we are going to give us further guidance on sample transportation. We want to acknowledge the following. We acknowledge the support of Minister of Health, Children's Local Government, and the staff, Mayanja Memorial. We are acknowledging Mayanja Memorial and TASO specifically because to me, these are the two partners who first actually agreed on integration when I talked to them and engaged them. Then together with UPMB, because for us, our community activities have been integrated for quite some time. We are just going on to integrate a few at sites. And we also thank all the rest of our Children's Local Government. Thank you very much. I beg to stop there. Thank you.
Thank you so much, Dr. Kamya, for the insights at the grassroots. These insights are very critical for us to learn from each other. And like we agreed in our different webinars, we are going to be picking on such very evidence-informed best practices to learn from and also guide some of those who are struggling. I have picked a number of things from your approach, especially where you are using available resources to achieve more than what the resource is for. That has been one of the things we have been trying to promote in the minds of the many, including at the center, the Ministry of Health, we are yet to get there, but we shall get there when we have such very live examples. You have a resource for, now we are promoting, I think all districts have resources for malaria vaccine and sensitization of the different stakeholders. You have the stakeholders, you have the space, you can use that resource for much more than just that activity it was meant for, to address the many indicators where you are still dragging behind or lagging behind. Let me now invite the Lira Regional Referral Hospital team to share with us what is happening at the regional referral hospital level. Over to you, the executive consultant Lira, to take us through. Thank you.
Good morning, ladies and gentlemen. I'm Eunice Apili. I'll be representing on behalf of the executive consultant. He's also available on call, and a bigger team from the hospital in case there are other questions to respond to and other clarifications to make. Welcome to this presentation. Next slide, please. So, our journey of integration as a hospital, when we got the circular, already something was happening in the hospital in line with integration. One of the things we needed to understand what systems already we have at the hospital, and this focus was majorly now towards integrating the adult clinic. As we are going to see later, our pediatric clinic, which originally was HIV clinic for the children and adolescents. When we started implementing EP3 around 2023, we had some challenges in implementing that concept. So we moved forward and integrated that clinic. Now, when we got the circular, that was an urgent need for us to move forward and think of how we are going to integrate the adult clinic, but also moving forward to integration of the PMTCT into the mainstream MNCH work. So as we can see before us, is that there was that urgent need. We looked at the different clients under the different DSDM models, and key to note, there were these facility-based individual management that we have, and then the fast-track drug refills, the ones that do not have any complaints, but they keep coming to the hospital. So we needed to plan as soon as possible to make sure they are taken care of. Next slide. So as a hospital, when we got that, at first it was hard to understand the guidance. As top management, the SEC, we needed to make sure that the leadership of the hospital is at the forefront of understanding this, but also working as change agents to steer the change. So what was done, again, we can see here before us clearly that the majority of the patients that we have are the adults. That total up to about the entire clients that we have in the clinic, totaling up to about 11,000. So integration was necessary for the adult clinic, and then we move on to the EMTCT section. But like I said, the pediatric center is 100% integrated as we speak right now. So we had to make a couple of changes. Just next slide again. So this is just to give us overview of what is happening in that children and adolescent clinic, that we are seeing both positive and then the negative children in the same clinic, which is an OPD for that age bracket, the 0 to 19. It's an OPD for them. And then we have another bigger OPD section for the adult clients. So like we said, originally it was a one-stop center for the HIV positives, but back in 2023, it was integrated. And what pushed us to do this was when we started the EP3 integration, we realized that coming to the general OPD, we were losing out on the adolescents, and they were not being screened because of the complexity of the OPD and mixing them with the adult clients. They don't usually open up. So there was that urgent need to have a clinic that supports them to open up, but also supports them to offer friendly services in that regard. Specifically, when you look at the sexual and reproductive health component, we were missing out on the adolescents. So that is why we moved to integrate that clinic. But key to note is when this was discussed with the leadership, they were well 100% and they supported the idea. 1 or 2 changes had to be made in the clinic, and then that clinic is now fully integrated. The provision, the availability of the other structures like the YAP structures, the pediatric counselors, as enabled to improve interventions in that clinic. So as I speak, again, I repeat, our pediatric section is 100%, pediatric and adolescents 100% integrated. Next slide. Now the move that we have right now is to strengthen, that's just a show, a pictorial presentation of how health education is being done. And in here, we have both the positive and then the negative. And this is a one-stop center. They have their meds comprehensively dispensed from there, not only art, also essential medicines for the rest of the disease conditions are dispensed from there. Next. Next slide. Now, when we got this circular in Feb, like we had the previous presentation, the first discussion was like, what do we do? What model do we take as a hospital? Do we integrate the HIV positive in OPD? So we sat down with the staff, top management, the leadership of the different sections, OPD team brought on board. I remember the first meeting that we had, like any other change process, we had a lot of resistance. It was like, that is not possible. For 20 years, for more than 10 years, 20 years, you have been operating differently. So how then can this happen that all these patients are going to be offloaded in OPD? No one had the best idea of how to do it, but then we had to start. The circular was out to support that. We had the second meeting. The second meeting, we had a half-half. A half is still resisting, the other half is already changed. And one of the things that they requested for by then said, this is something possible. Later on, we started getting that remark that this is something possible. But there are a number of things that we need to be supported with to make sure that we can start well. One of the things that was brought out, number one, is the infrastructure issues. OPD is really crowded. It's a one-stop center for all the OPD services, including a section for casualty. So the infrastructure was a little bit complex because even only with the current existing OPD members by then, OPD clients by then, there was already crowding. So as you can see, this is a component of the upper picture. So we had to get back to the drawing board with top management again at the forefront of this, and they're like, what do we do as a hospital? And then as a hospital, top management actually decided taking patients to OPD, HIV positive patients to OPD is going to be a little hard based on the issues that we had already identified from the clinical assessment that was done. So we decided as a hospital that the HIV clinic, like we see it down there, we have that infrastructure, we have the human resource that is already there. One, they're already good at management of HIV. Now, again, 2 years ago, when we started integrating NCDs into HIV, a greater number of the people who were already at the art clinic were trained in the management of NCDs, that is hypertension, diabetes, and then the mental health. Even then, we made changes. One change was in the human resource to just make sure that we have a human resource team that does not only look at HIV, but also looks at this other component of the NCD. So from that background, we already had a team that was built to support this other component of the NCD. Still with leadership and the background, we have decided to integrate the HIV clinic, what was called the HIV clinic originally, but right now we are calling it the specialized clinic. That is going to take care of the specialized medical clinic, which is going to take care of the HIV clients and all the NCDs. And as I speak right now, a number of changes already have taken place.
Change with my side, or all of you are getting interruptions.
Before, please, the slide before. So, and these changes has tackled only all the component of the building blocks as we move to strengthening the medical specialized clinic. We've tackled all the components of the building block. One, the leadership is behind the change. They are steering the change. They are the change agents explaining to the staff what is happening. And then we usually have a senior management meeting every Wednesday, what we are calling the parliament. So the leadership keeps talking about it. This is what is happening. This is what the ministry is fostering, integration of services, and then a patient-centered approach. Then human resource, what was done, the human resource that has not been at the forefront of HIV management already hinted that they need an update training or mentorship to allow them settle in HIV clinic. So we conducted that training. A component of the OPD staffs were supposed to train in 2 phases. So the first phase was trained. Now, with the initial background of NCD management that they are good at in OPD, we added on the component of HIV and then made reallocations. We made reallocations, work on the duty roster, and make sure that the HIV clinic is not only now left to the project staff, the G2G. Now we have the GOU staffs that have been allocated to the clinic. We are allowing them to settle. We are supporting them to settle, and then make sure that they are updated on managing an integrated approach. When we come to the supply chain, our ART clinic already is a one-stop center, but the majority of the medicines that we have in the ART clinic has been the ARTs, and then with a limited component of the opportunistic infection medicines. But as we stand now, we are expanding that envelope to make sure that the lab, the pharmacy becomes a one-stop center for all the chronic conditions that come to the center. Now, as we do that, we are also doing pairing. Now, we are also doing pairing, the most experienced and then the people who are joining, so that there is that one-on-one mentorship that goes on duty. I can ask about art, what is this, and I can be supported to manage the complex cases of maybe the diabetes. So that is where we are as of now. All the systems have been set. The service delivery component, there is 1 or 2 things that need the financial component, like there is an area probably that needs to be remodified to take care of the resuscitation issues in case any arises in the clinic, and top management is following up on this, and they have promised that they are going to support along that line. So as we stand right now, we are ready to kickstart everything. The foundation has been set, human resource allocated and being trained and getting ongoing mentorship. The supply chain has been remodified. Human resources for health has been repurposed. We have also had a component of thinking, what do we do for the community arm? For the community arm, those ones who need follow-up, and then the prevention aspect in the community. And then top management is taking that up, but already like we have a few of the community
time, please
and they are
plan
ready
to wind up.
support
Plan
with
to
that.
wind up.
Next slide. This was just this is just to show to us that as a hospital we are already taking care of the other NCDs. The medical specialized clinic is actually already taking care of the NCDs, other NCDs, hypertension, diabetes, and now the bigger component being HIV. But one thing that we are saying is it's a phase out approach. We are using QI as we learn and scale up. And then next week, we have our complex cases of the DM cases now being shifted into the ART clinic. One big challenge that we're already having, maybe one is to talk about the G2G, very experienced G2G staffs that needed to be taken up into the GOU. The processes the processes are not clear. We need that support. But already one thing that we are seeing and anticipating will continue to be a problem is the parallel systems that we are having. We have right now in the clinic, we have the ART access, which is supporting to synchronize information from the community drug distribution points. That is parallel. We have Uganda EMR, which is taking care of the positive patients, but we also have EAFIA as part of digitalization for service delivery in the hospital. And all these systems seems to be parallel for now, which means it will be much more labor intense to run parallel systems. So our urgent request for ministries now to support us and synchronize all those systems. But by and large, as I speak, we are on the right track. And I love the acceptance now from the staff. They are the ones talking about the integration, and anyone can speak about it. I'll stop here and request if the director, the SEC has any addition to do that. Thank you, and over.
Thank you so much, Eunice, for the experience at Lila. We'll now open up. We've had a number of presenters, and we'll have, you can show the agenda, please. I see a number of questions in the chat. I don't know how some questions have been answered. Isaac, you can check if there is a particular question which we need to specifically provide guidance on. That is still Okodelia. Yes, so we are on the discussion, and I want to pick the hands that are out there that have not put down their comments to say something. Actually, you had your hand up before. It is back. Let's hear from you.
All right, thank you so much. I really appreciate the Ministry of Health for spearheading this change in the management models, and I believe it will really help us. My concern is about the engagement of the key stakeholders, that is the clients and the communities. I have not seen any like proactive plan to engage them and inform them about this integration process. We seem to be focusing on the health service delivery side, the infrastructure, the health workers, data capture systems, and we've not done maybe any preparation for sensitizing the communities we serve. Thank you. Back to you.
Thank you. I think that was on under standard 1 and 2. If we share, you'll be seeing how you need to engage your stakeholders, the clients, into the new arrangement that you are starting. Ronald and Richard.
Thank you, Chair. My name is Richard Damba Tumusime. I work with Walter Reed. And I want to thank you for this meeting and the presenters. But in Walter Reed, we have engaged on rolling out integration, and we are making good progress. But one particular question we face is about TB. because TB is listed among the chronic conditions that should be integrated, and given its infectious nature, given that most facilities tend to be leaning towards adopting the chronic care model and creating chronic care clinics and merging the rest of the chronic conditions into with managing HIV. So if the circular guided that even TB clinics should be closed and merged into the chronic care model, what is the guidance, given that its infectiousness and the uneasiness the health workers are finding with merging it in the management of the rest of the chronic conditions? Thank you, Chair. Back to you.
Next was
It was Ronald.
yes. Then we shall have
Yes,
Esther and Isaiah after.
Thank you so much, everyone on call. I'm called by Ronald from Awach Health Center for Gulu. Yeah, I've been able to appreciate the integration of services into OPD. And key to note, I saw all the two presentations from Kayora and the one of Golera Regional Referral Hospital. It seems like they resonate very well, but then the challenge is they didn't come out clearly in their patients' number. How was the follow-up for those ones who have missed the appointment? How are they handling it? How is it integrated into the services? Who take care of it? And by so doing, I think we would have now gotten to know how do they feel in the community? What is making them get lost? I didn't hear them coming out on that. Could they respond if at all there is any loss to follow up happening as it used to be happening? Is it more or is it reducing? Thank you so much.
Thank you for that. Esther.
Okay, thank you so much, Dr. Stavia. I am from Mbale, and in Mbale, for the last, I think about 6 months, we started implementing this integration at the regional referral hospital, at one of the health center FOS, and at one of the health centers RIS. And what I can say, this can really, really work, but at regional referral, we need the buy-in of the physician, because at regional referral, we merged the NCD clinic and the art clinic. But if we have the physician that is in charge of all these clinics be on top of the game, we can succeed. And then for the Center 3s, I'm glad Dr. Kamya presented, because we're able to visit him in the Chiruhura, and we saw what they were doing. For the Center 3s, the OPD model is the way to go. However, of course, the main challenges for this integration have been around the NCD supplies and data management for the NCD clients. If we can address that, then it will be good to go. Over to you, Chair.
Isaiah?
Thank you very much. Good morning, everyone. This is Isaiah from IDRC. Just coming in regards to digitization. It's a very good and beautiful thing, but however, we realize that power continues to be a problem at some of the facilities, especially in rural areas. You find that a facility can run for a week without power, and yet, of course, the need for digitization is high among us, and which is a beautiful thing. What is the strategic plan that we have to ensuring that such facilities continue to have power to facilitate digitization, so that people don't go back to OPD books once the systems are integrated? Do we have a plan of ensuring that all facilities receive solar panels so that they are naturally powered? and of course to reduce on the cost of power consumption. Yeah, thank you. I submit.
Thank you, Isaiah. I will have the 3 hands which are up, and we shall stop the Q&A there. The rest, put your questions in the chat, please. So I will not entertain another hand. So I have Arthur, Happy. Oh, another person has put up their
Okay,
hand.
so
So they are 4. Arthur, Happy, Winnie, and John Bosco. 1 second each.
all right. Thank you, and thank you for the presentations. I think it's a good initiative. Comment one is I feel we're mixing two things: patient-centered care and integration. Might be best to keep them separate. Otherwise, when you overload an initiative, it may fail due to the load. In terms of wording, it should not just be moving away from disease-focused care, but disease treatment. There's too much emphasis on looking at a patient as diseased and requiring treatment. So we should also move, the patient-centered care should be taken away from this problem of disease and treatment, which I think was alluded to as a problem that manifests as overprescription. I submit.
Thank you for the comment. Happy?
Thank you very much, Doctor, and everyone. I appreciate the discussion here. Just my addition, one speaker said that integration must start at the top. So among the things that also must integrate is that we advocate targets of TB and HIV. They should not be like left to the IP to be done to follow them up, to even introduce them to the district, the DHO's office. We would rather all targets, including malaria, death cases, and whatever, including HIV and TB, must come from top to the DHO, and they will trickle them down. And even when it comes to supervision and demand of results, again, the same process. They must demand results from the DHO, who will also trickle down. Now, our role as the IPs, we should be in the background to also push and monitor and offer technical support. And then also with time, if in the event that things streamline and funders are back on board, we pray that the ministry also will take an upper hand in directing them where to put their support. The frequency at which they demand things are the ones that make IPs operate parallel. But if they know that they're demanding results from the ministry will trickle down to DHO to the facilities. We are in the background. We shouldn't be seen taking the upper lead just because of the pressure of the donor. Of course, these are things that we shall continue discussing as time goes on. I appreciate, and over to you.
Thank you. Donor perspective and IP is there. I think the last one is, the last two is Winnie and Bosco.
Thank you very much, moderator. Good morning, everyone. My name is Winnie Nabukera Nance, and the CEO Little Win Foundation. We offer soft skills, entrepreneurship, and work readiness programs. I want to start by by thanking all the presenters. Thank you very much. And my reference is going to come from what Dr. Ronnie shared about the next steps for the capacity development. I feel that in our training priorities, we actually focus more on the technical abilities, which are really very good. But I feel as we are thinking about shifting from disease-based to patient-centered service delivery, I feel we should focus more as well into addressing interpersonal skills and gaps. And in that way, I feel soft skills should be an answer for us to be able to achieve patient-centered care, where the providers are going to learn how to communicate very well, to build trust, to be problem solvers and critical thinkers, but also to nurture these patient-related relationships. So I feel in the moving forward, if we want to achieve this, we should also support the providers on the other side. That will also help to address attitude and mindset change amongst the providers. Thank you very much.
Thank you, Winnie. John Bosco. All right. John Bosco.
Yes, good morning, everyone. This is John Bosco Rech from Oyam District. I want to just give a few highlight on this. Oyam District is working quite well, and Oyam has about 17,000 clients on heart. And as a district, we thought of if all these clients are brought back to the OPD, like for example, Anyeka Health Center 4, which has about 5,000 clients, if they're all brought back to OPD, would actually make this other client not to get the services very well. But fortunately, when the partners were working, Oyam District was not making them to work in isolation, but they were working together with the health staff. So we have maintained the art clinic in where they were, because looking at the arrangement that we have made at the art clinic, the filing system, the recording, and then the EMR, all those cannot move back to the OPD. And also we are able to track on the lost client. Immediately, if somebody is lost, we are able to track because we can go to the EMR and extract the audit tool for both the general client and then the PMTCT client and then the children and adolescent. We are able to track that and then get it on the audit tool, and we are able to see who has not got any service. But all that cannot take place at the OPD because the OPD will actually be overcrowded. So we have maintained the art clinic there with the staff that we had assigned at the art clinic. And we think that one is working for us until when maybe, and we are trying to also convince the community linkage facilitators to continue working because some of these art clinics were even being manned by the community linkage facilitators that are actually our own people in Oyam District. And letting this go to the general OPD would mean that we have disorganized the art clinic and we shall not be able to keep proper record for our client. Our suppression rate is at 95%. And that means under the DM model, we are able to categorize our client into the 5 models. And the community model, the CCLAD and the CCLAD and the CDDP, we are able to give these people their medicine, and with the policy of the multi-drug refill, we are able to give these people for 6 months. And the 6-month drug refill is making our art clinic also decongested. And also the fast track drug refill, we're also giving them for 6 months.
You were given 1 second. I think you are using more than.
The question that I have is, that I have with the many words that I've put is that, how are we going to maintain the records of the client that are getting medicine and then and recognize those ones who are getting lost, and we're able to bring them on track? And then 2, how are we going to the bulkiness of the tool is our issue. The tool, the tool of the art clinic is actually bulky. How are we going to make sure we get a tool that can be written within even just 5 or 6 minutes? The tool is very bulky. We need to reduce on the tool that is being used.
Thank you so much for the submission. I want to propose that we now get a few responses. We will not respond to every question you have raised. Some of your questions were comments. I'll start with Ronnie, and then we'll go to Kamia, and then lastly, Lila. Then the Director General will help us to wind up with the questions around the guidance of how to handle human resources that were under the IP as the districts now start recruitment of staff, those who have wage. Over to you, Ronnie.
Thank you so very much, Chair. And I take this opportunity to appreciate all those that have attended, surely, because the questions that have been asked are very relevant and they point to a team that has listened in very well. Chair, there were no major specific questions that were pointed to me. The bulk of them were comments that were seeking clarity, which has already been responded to. The bulk of them in the comments that people have made. But key to note is the aspect of human resources for health, the rearrangement, and what are we going to do in areas where we're having low staffing levels. Chair, we have indicated that through this optimization of resources, we're not only focusing on money, but even the personnel ourselves, we're going to be able to reorganize. Where you've been having to require 10 sets of healthcare workers to run vertical services, you're going to use those same 10 healthcare workers to run several clinics in the same setting, meaning that these 10 or these are so many that you already have with you are going to be put in the same setting to be able to deliver this service at one sitting rather than separating their efforts. So there's going to be synergy in the efforts that are going to be leveraged from the different teams rather than separating ourselves. So I take only one concern that I may need to possibly emphasize here, that we need to be positive in the way we are embracing this integration agenda, because it begins with a mindset change and accepting the fact that we need to work in an integrated manner. And it's only then that we can reorganize our minds to think out of the box and rearrange the different arrangements or setups that we have in the facilities to make sure that we are able to redefine the process flows within the facilities and make sure that everything is running as is expected. Chair, there was another concern that was speaking to the aspect of dispensing of medicines from the consultation rooms in a view of people living positive with HIV/AIDS. And I wish to set the record straight that we're not encouraging people dispensing medicines from the consultation rooms. We will have one
Thank
dispensing.
you.
No, Chair, I just need to emphasize this.
Thank you. Yes, yes. I am saying thank you for highlighting it.
Yes, we're not encouraging people to dispense medicines from the consultation rooms. We will have one dispensing area, and we will have consultation rooms for consultations and prescriptions, and people will go to the pharmacies or the dispensaries and they'll get their medicines. The arrangement therein will depend on how we set our dispensing windows, just to make sure that we're able to possibly serve our patients better. And in any case, it's just within the minds of we, the healthcare workers, that the brands of medicines that or the packagings of the medicines are stigmatizing in a way, because we feel that when a person gets a tin, then that means it's HIV/AIDS medicines. No, we have so many medicines that are packaged in tins, and so it's all about we changing the mindsets of primarily ourselves, because we are the chief promoters of stigma, and then we speak to our clients or our patients that are coming to us to make sure that they are able to embrace this. It all begins with us, and our patients will be able to embrace this. Thank you. I'm back to Chair.
Thank you for that. And this also speaks to the last comment we got from OYAM, who have refused to implement the circular and have maintained the HIV clinic parallel. Please learn from the colleagues that are trying to see how to go into the integration mode of service delivery. And like Dr. Ronnie said, we will not all reach there immediately at the same time. Some people will learn slowly, others are already ahead of us, even ahead of the Ministry of Health. So we know you will get there also in OYAM, and you will think about your situation and you see how best you can embrace the integration agenda. We are here to keep you supported, and we'll definitely reach out to you for more technical support. Dr. Kamish.
Thank you very much, Stavia. Are you getting me, Stavia, now? Okay.
Yes.
Hello?
Yes.
Thank you very much,
Yes.
Stavia. The one comment about lost follow-up, I can give you the example of the clinic of Rushere, because for it has been there for more than 1.5 years, almost coming to 2 years. When it was started, actually, I was invited to say, now the problem, the clinic is going to have issues. And definitely there was lots to follow up. But using CQI, because the change in management has to have challenges, using continuous quality improvement, we are able to track through most of those clients, and then we brought them back on treatment. There will definitely, when you are trying to make a change, there will be some negative impacts. But if you are slow and you are using CQI and you are able to intervene, you will find that these clients, slowly by slowly, will be able to get them back. Thank you very much.
Thank you, Dr. Kamil. The Lila team, any comment?
Thank you. Thank you. A couple of questions directed to us. One is, aren't we worried about stigma issues? Apologies, I didn't run through the entire chat, but most of them were repeated. Aren't we worried about stigma issues? Yes, as we manage the change processes, there are usually risks and then fears that we have anticipated and tried to make provisions for them. Stigma issues, we have anticipated it, that as we start combining the clinic, it will arise. But one or two strategies that we have put in place is that right from triage, the way we collect the books, the way we triage the patients does not leave room for any stigma to say that, you know, for you, you're bringing in a file, someone else is bringing in a book. We do it in a way that depicts uniformity, and therefore it's very difficult for you to note. It's only inside when you enter to see the clinician that you now see that my book has additional file and probably my book does not have any file. We've anticipated that and tried to make provisions. So issues around loss to follow up, we are planning right now, like there is no any other cadre, probably the project cadres are not in the hospital. The follow-up system that we have always had in standalone art clinic has been so robust because of the big numbers that we've had attached to follow up the community health workers, the volunteers that we've had. Right now, we've anticipated them, and one thing that we are doing that should help us improve the aspects of follow-up is to update patient's locator form at every visit. Talk to the patient and ask them, could you have changed phone number? Give me a number that is authentic and you think we can reach out to you. Now, when we have such updated, we are going to definitely have to do task shifting. The other component of the community health workers might not be there, but as we task shift, we can assign a counselor who is now going to be responsible for making these phone calls. We have phone calls in the clinic that the hospital has allowed to continue supporting it. So we make phone calls, and we think with the updated locator form, we should be in position to reach many. 1 or 2 attempts, but we should be in position to reach many as we look for any opportunity to do the physical follow-up as the need will arise. Now, someone asked a question about how are we thinking about sustainability. Now, how we have thought about issues around sustainability started right from when we started thinking about sustainability. How integration, how are we managing the change processes? Like we say, top management is way behind this. They are the champions of integration. We have the specialists on top of this, the physicians, and then the pediatrician. So we think when we have that top management and senior management understanding, there should be the sustainability issues should be handled, because most of these decisions are actually taken care of at that level. Human resources is at the forefront. The SPNO understands now integration so well. So whenever she's making, in a meeting yesterday, whenever she's making any duty allocations, she considers this integration and make sure it is supported. Now, as we do this, someone is worried about records keeping and if we are not going to lose a lot of patients level data. But now, yes, the systems are still parallel, something which we think the ministry is working up to. But as we do this, we are not compromising, the preaching is we are not compromising any quality of care. If a patient, all these parameters that we have been picking from patients, including the audit tool, including entering data into EMR, that is going to be taken care of. We are now looking at how do we build capacity? How do we repurpose the human resources that are available in the system? In a nutshell, all these components under the health systems building block, like we had hinted, we have looked at them one by one and anticipated where the challenges could come in these processes of integration, and then supported them. The funding issues have been brought clearly right now. Even at the initial stages, there are issues that we needed funds. There's a small space that we need to remodel, and that has been put forward to hospital management, and they said they are looking at it. There are issues around providing more seats for probably the additional patients, but also improving the systems in the clinic to make sure that patients are attended to as fast as they come, so that we do not have any crowding. Thank you, Chair.
Thank you so much. Thank you so much, Lila team. And I think most regional referral hospitals are taking the lower. I've shared this slide for those of you who did not understand the process we are talking about. They are taking the lower approach, where we have the general OPD and the chronic care OPD, whereas I think it was from Dr. Kamia, they are taking the upper approach in terms of having the OPD and chronic care in the same building. So we have taken note of the concerns about the parallel data systems. This will take time, but we are surely going to be working on this as we continue this integration agenda. We have taken note, and I want to encourage all the DHOs and the partners who are here that we need to use the system so that we are not giving different commands. And now we shall have people who are moving in the districts, in the clinics from the IPs, teaching integration. When the DHO is not on board, we need to start from the DHO's office and we move together. Let's not run the system when the owners of the system are available. And then the buy-in of physicians, Dr. Ronnie, please take note of this as we promote the chronic care clinics. The physicians in charge of the medical conditions need to be up and able to guide the teams on how this integration is going to happen. The TB issues, we are not dropping any form of IPC down as we promote integration. So the triage is going to continue. TB patients can only be identified if we are screening all people who are accessing services. After you have identified them, they will be initiated on treatment. And after they have been initiated on treatment, they are no longer a very big threat. What we are saying is that in your clinic flow, as you manage the chronic care clinics, if you have new patients, they need to be given the relevant protective equipment like masks so that they do not become a risk for others, or they can be catered for in a separate area or fast track through the system. So the IPC measures that we have always talked about are going to continue as part of the clinical care package and safety for the health workers and the users of the health service. I want to now invite the Director General for specific comments, especially on the streamlining of partner-supported staff in the districts and hospitals who are doing recruitment. Over to you, DG. Okay, looks like the DG is not there, but this will be, like we had discussed, the guidance will come through. And I think in the circular, if you read it carefully, you should have seen something mentioned there. The recruitment is for those that have. Okay, go ahead. Go ahead.
You know, I didn't have the authority to unmute, so thank you very much for allowing. I know other members have already dropped, but I want to appreciate all those who attended. I want to also recognize that we had a number of partners in the line, online. And I want to just mention it from the very beginning that it can't be perfect, but we have to start. You can only not be the best physician, best surgeon, or best whatever, unless you practice. So I think we need to be able to move. We shall have challenges, we shall need money, but we will need to be able to see that even without money, we should be able to do something in semblance to integration. I want also to mention that as a ministry, we are putting together a national framework, because right now we have started from the middle. Ideally, what we should have done the strategy, guidelines, but we couldn't have time for that. So we started running before we put those, but we are working with the partners, CHAI and the FDCO, to put in the national framework. There's a consultant who is working at putting up all these pieces together, and then we shall be able to do, because what we are talking of here is integration at service point, but also we need to speak of integration at planning, but also we want to speak integration in procurement. Like what I think government saw this coming a long way. Actually, having NMS procured medicines for the public facilities is really already another form of integration. I think in the next meeting we shall have experience from a PNFP, so that we can also be able to see that how is the PNFP private not-for-profit subsector working on it. We'll continue doing sharing. We shall move these learnings to the regions, but also we want to move the learnings to the facilities. I want to thank Lera, Dr. Kamia, and all the teams for your participation. Let's continue with the conversation. I think we need to have where members can be able to drop their comments. There are many comments which have been online. I hope the Secretariat has captured them. And I think all in all, we are good to go. So let's just be able to address the few remaining bottlenecks, and then we can be able to do that. As a ministry, we are looking forward to support you, and also we are looking at that our partners should also be able to fall in the line we want this to do. And this is one of the aspects of the sustainability roadmap for this country, that as partner support goes down, we need to be able to do things differently. We don't have the privilege to continue the way we have been wanting to do things. In terms of representations, I think we'll have civil society will represent the communities, but we shall also engage with communities. And we really would want that, even at first level, please engage with the local leaders, with the communities, and see that this works. So thank you, facilitator. And I want to end there.
Thank you so much, DG, for that further guidance and clarity. And I want to thank everybody who has participated. We have some few questions where you can guide us on the next topic for discussion. Like the DG said, we'll continue the discussion online, but also physically reaching out to you. But we want to get your view on what should be emphasized quickly for the next webinar. So I want to ask Dr. Maureen and Tim to give us the survey for the health workers to give us input. Thank you. Kindly load the survey. Is it in the chat? Is it on the screen?
Yes, thank you very much, Dr. Stavia. And we would like to appreciate the ministry leadership, senior management, top management for this opportunity. Isaac is going to put the survey within the chat. We also take note of it's already in the chat. Yes, thank you very much. So kindly click on the link, and this will take us to 5 very short questions. We would like to get your input as critical stakeholders on the way to conduct or hold the future webinars that will be held in line with this initiative. Thank you very much. Over to you, Dr. Stavia.
Kindly click on the survey and fill in the form. We'll give ourselves a few minutes for that exercise to be completed. You can be updating me, Isaac, on how it's going. At least if you have over 100 or so responses, you can.
So far we have 10, so we'll wait for the others to submit.
Please submit your responses. Thank you. I'm going to share the slides.
But I would also propose that
Yes.
in fact, because we have lost some numbers here, we can also send the survey on their mail, since we've received a copy of their emails as they were joining this meeting. We could save some
I'm
time
also going to
with that.
put it on the DHO's chat if you allow. Yeah, DHO's. That's that. Okay, let's also saturate it in the different for where we sent the link so that we can quickly end the discussion. The slides will also be made available on the different, using your emails that you submitted, but also on the different fora that you are on. DG, you can kindly close us off. Thank you.
I thought Stavia, I closed. Thank you. Let's continue.
Thank you, everyone. Thank you, DG. Meeting adjourned.
Thank you, everyone. I will let people just
Isaac,
access the.
Isaac, don't close it off. Let the people just first continue using the survey, the link as before closing it for all.
Yes, yes, that's not a doctor.
Okay, please.